Good morning. Today, for the next 20 minutes, I'll be discussing approach to acute vestibular disorders in emergencies. The three important vestibular disorders which a emergency department physician sees are stroke, particularly in posterior circulation, migraine, and BPPV. I have divided my talk in five sections. The first four sections are approach, and the fifth section is basically the HENS examination to differentiate acute stroke from the vestibular neuritis. That is particularly in the hyperacute stage when the patient is eligible for thrombolysis or other mechanical thrombectomy, etc. Number one, dissection of the symptom vertigo. If a patient comes to emergency and says that I am dizzy, chakkar aa rahe hain, do we need to inquire in depth when he complains so? Yes. The short answer is because seven different medical conditions the patients suffering from may complain that chakkar aa rahe hain. These are orthostatic hypotension, diplopia, ataxia, acute confusional state, epileptic fit, lightheadedness, and syncope. So make it sure at the first go only that it is a vestibular disorder. 17 leading questions which I ask are as under. Chakkar, what means that? When did it start? Acute or subacute? Any previous history of identical episodes? How long does each episode last? Are the surrounding objects spinning? Feel like oneself is spinning? If any one is felt as in 2 or 3 above, then what if? Do you feel dizzy while lying down, getting up, turning in the bed, looking upwards and bending forwards? Do you get dizzy just on head motion? That occurs in every type of true vertigo. Do you feel dizzy when you see nearby objects or people moving or shaking? Do you stagger while standing or walking in a way that people around you also can notice? Do you feel a fear of falling while standing or walking? Do you lose balance while walking and fall to the ground or come close to falling? Do the surroundings appear to be tilted to you? Do you lean to one side while standing or walking? Has your hearing started to deteriorate? Do you experience buzzing, ringing, or any other sounds in the ear? Do you also get headache along with dizziness? Any history of migraine, hypertension, diabetes, or stroke in the past? Do you experience intense dizziness immediately on hearing loud sounds, coughing, or straining while defecating? Current medications, this is very important, particularly drugs like pregabalin, can cause severe rotational vertigo as well as downbeat nystagmus. Third is pattern recognition. Basically, vestibular neurologists and general neurologists see three patterns. The first is the acute monophasic illness, which comes and goes away. Acute unilateral vestibulopathy is the number one cause. That is vestibular neuritis, vascular stroke, mostly in posterior circulation, psychogenic, and seizures, tornado epilepsy, though rare, should be kept in mind. Second is recurrent fluctuations with increased severity and deterioration. The classical example is Meniere's disease, multiple sclerosis, and transient ischemic attacks. And third, sometimes when these patients are frustrated, they also may come into emergencies. These are progressively dizzy patients. They have progressive deterioration from the onset, and these are the patients with acoustic neuroma, brain tumor, cerebellar degeneration, and hereditary ataxias. This is very important for knowing the etiology of the disorder. Duration of attack. If it is seconds to minute, the answer is vestibular paroxysmia, BPPV, or PLF. Minutes to hours, posterior circulation, TI, or vestibular migraine. Hours, Meniere's disease. Usually it is from more than 20 minutes to 24 hours. Days to weeks, vestibular neuritis, posterior circulation, stroke. The core topic of my talk today is recognizing stroke in acute vestibular syndrome, especially in the hyperacute stage. In mid-80s, when I was a medical student of undergraduate medical school, we were told that an isolated vertigo is never a symptom of cerebrovascular disease, TIA, or stroke. However, in article in 2012 from South Korea, published and found that isolated vascular vertigo can occur from acute infarction in 5 regions of the brain. These 5 regions are nodulus of the cerebellum, lateral caudal pons, that is the root entry zone, flocculus, vestibular nucleus, and the dorsal insula, that is parieto-insular vestibular cortex. Here it is important to know that these patients with acute infarct in dorsal insula do not have nystagmus, and therefore the Hintz examination is not useful in such cases. Unfortunately, MRI diffusion weighted imaging conducted within 48 hours of stroke is falsely negative in around 12 to 18% of acute vestibular syndrome patients. The important thing to note is this study by our own renowned Professor P.N. Saileja when she was in Canada. They studied the frequency of diffusion weighted negative cerebral ischemia and clinical factors associated with circumstances. They performed MRI including diffusion weighted imaging in patients with stroke, 3 Tesla MRI and TIAs within 24 hours of symptom onset and again at 30 days. Around 103 out of 401 patients had negative initial diffusion weighted study, and when they repeated the study at 30 days, 6 out of 26 had infarcts on follow-up MRI. So what happened to 20 out of 338 patients? The 338 comes by removing the patients who had TIA. They had a negative delayed MRI at 30 days also. So around 6% of patients with acute vestibular syndrome may not be picked up in delayed MRI at 30 days, even at centers where the dedicated stroke units are in function. Now see the irony, 3 decades after, now there are criteria for vascular vertigo and dizziness in 2022. Acute prolonged vascular vertigo oblique dizziness, 3 criteria: acute vertigo, dizziness or unsteadiness lasting 24 hours or more, imaging evidence of ischemia or hemorrhage in brain or inner ear which corresponds to symptoms and signs and other findings not better accounted by any other disease. They look like a political criteria because we know the imaging cannot be relied upon in the management of acute, hyperacute ischemic stroke. So, acute vestibular syndrome, the definition was modified to make the Hintz examination applicable to it. Acute vestibular syndrome is a clinical condition characterized by dizziness or vertigo that develops acutely over seconds or minutes or hours and is accompanied by nausea, vomiting, gait instability, nystagmus, and the head motion intolerance, and persists for a day or more. So, AVS spontaneous. The biggest challenge for a neurologist is to differentiate acute vestibular neuritis from the posterior circulation stroke, which is done by Hintz and Hintz plus examination. The triggered acute vestibular syndrome is a overlap syndrome with trauma and traumatic hemorrhage, subdural, subarachnoid, etc. And this is not the topic of discussion today. Removing it here. So the Hintz examination. When to use Hintz? A patient who is acutely dizzy, persistent vertigo, more than 24 hours. There is nystagmus, normal full neurological examination. Purpose to differentiate the central causes of AVS, that is the posterior circulation stroke, from the peripheral cause, that is the acute vestibular neuritis, which is now called acute unilateral vestibulopathy. What is Hintz? I have explained this in a 3-minute video here. It is a clinical bedside neurovestibular examination that differentiates the cause of acute vestibular syndrome, whether resulting from acute vestibular neuritis, a peripheral cause, or a stroke in posterior circulation, a central cause. The HI stands for the head impulse test, N stands for the nystagmus, and TS stands for the test of skew. The first part of the examination, the head impulse test, tests the VOR integrity by observing the eye to maintain a fixed point in space during the disruptive head movements. A negative head impulse test is normal but is indicative of a central acute vestibular syndrome in the context of Hintz examination. A positive head impulse test is abnormal and is considered to be pathognomic of acute vestibular neuritis. The nystagmus is the most objective sign to distinguish between a peripheral acute vestibular syndrome from a central one. The peripheral nystagmus is usually unidirectional, mixed, horizontal, torsional, while a central nystagmus is either vertical, or if it is horizontal then it is bidirectional, gaze-evoked, that is on right gaze it is right beating and on left gaze it becomes left beating. The test of skew is done by alternatingly covering and uncovering the each eye and looking for the deviation. A no deviation indicates a peripheral cause, that is acute vestibular neuritis, although in some cases it may be present. A diagonal or the vertical correction during the alternating covering and uncovering of the eyes indicates a central cause and is indicative of acute posterior circulation stroke. So, summing up the hints examination, the clinical signs, the head impulse test, nystagmus, and the test of skew. If head impulse is positive, the nystagmus is unidirectional means torsional, horizontal, and the test of skew is negative. If all three are present, it is indicative of a peripheral acute vestibular syndrome resulting from acute vestibular neuritis. And if any one of the three is present, that is a negative head impulse test, bidirectional gaze-evoked nystagmus, or a positive test of skew, that indicates a central cause for acute vestibular syndrome. Vertical nystagmus may also be added to the bidirectional gaze-evoked nystagmus, and our threshold for the central acute AVS is very low. Only one out of the three criteria are, or the hints are just essential to make a diagnosis of central hints. So, hints is not indicated in patients with distinct neurological symptoms and signs of extreme localizing value like hemiataxia, ataxic hemiparesis, dysarthria, dysphagia, internuclear thermoplegia, hemiparesis with cranial palsies, and highly localizing central nystagmi like convergence retraction nystagmus, periodic alternating nystagmus, and cross-coupling nystagmus. This is a patient acutely dizzy. On right gaze, the abducting eye shows a nystagmus and there is restriction of abduction of the left eye. The diagnosis is left internuclear ophthalmoplegia. The lesion localizes to the right, the left dorsal midbrain. This is a lady who had acute vertigo in emergency. She was seen by me, and on close inquiring, she disclosed that suddenly she has started feeling that the objects in front of her eyes are moving up and down rapidly. And you can make out that there is a vertical nystagmus. No prior history of any illness. Test of skew is slightly difficult because patient already has a vertical nystagmus, and if a diagonal vertical movement of test of skew is difficult, so what to do in such cases? Slow down the speed of the video. Here I did the same. Over and above the vertical nystagmus that you see, there is a corrective upward movement when the eye is uncovered. So the test of skew is positive and it is consistently present, as you can make it out. The tandem rhombox and walking were normal. Half minute she could stand in tandem rhombox position, and then she could walk easily tandem more than 10 steps. Finger nose test was normal bilaterally. There was no dysdiadokinesia on right or left. So the only symptom was acute oscillopsia, and this adds to the list of acute vertigo isolated event. And there was a dorsal medullary infarct. On investigation, she was found to have APLA positive state. This is the MRI of this female. This is a patient again acutely dizzy, and he had some ipsipulsion both in the eyes as well as truncal. The eyes are divided to the left. On opening, they come to the straight ahead gaze. There is a corrective second. So this is classical of the ipsilateral dorsolateral infarct. This is the truncal lateropulsion you see in this patient. Initial MRI was normal. The delayed MRI done after 48 hours shows acute left dorsolateral infarct. This is a 56-year-old patient, acute vertigo, hypertensive, coming to the head impulse test, which I carried out at 2 speeds. You can see a right beating nystagmus, and the head impulse test is positive to the left. Clip speed was reduced to 50%. And you can clearly see acute unilateral vestibulopathy left was the diagnosis. This is a 73-year-old patient seen in the second week of November 2024. Acute true vertigo for 24 hours, vomiting and symptomatic at the time of examination. Head impulse is negative. Bidirectional gaze-evoked nystagmus. Test of skew positive. On right gaze there is a right beating nystagmus. On left gaze there is a left beating nystagmus. Alternate cover test showed skew deviation. This goes down, this goes up. Bilateral cerebellar hemispheric infarcts. One of the infarcts in the right cerebellum was in the paraflocculus area, as you can see. Basilar and bilateral posterior cerebral arteries were stenotic. Central patterns of the nystagmus, bidirectional gaze-evoked nystagmus. What is the eye movement machinery of the brainstem and cerebellum? The 5 important structures are saccadic generators. For vertical, it is RIMLF, and for horizontal, it is PPRF. Gaze holding is done by the vertical for the INC, that is interstitial nucleus of Cahal, horizontal by nucleus prepositus hypoglossi and medial vestibular nucleus. The gaze holding is enhanced as well as the smooth pursuits inhibit anterior canal pathways is flocculus and paraflocculus. The fastigial nucleus is important for saccadic accuracy and nodulus is important for velocity storage. So with this anatomy in background, we can make out that the paraflocculus was involved in the previous patient and that's why he had a gaze-evoked nystagmus, which was bilateral. 28-year-old female seen in May 2024. She had episodic vertigo, came in emergency with vomiting unsteadiness. Bidirectional gaze-evoked nystagmus, choppy smooth pursuits, HIT negative, skew deviation negative. Required one-man support to walk. 51-year-old mother also had gaze-evoked nystagmus. EEG showed generalized epileptiform discharges. On right gaze, you see a right beating nystagmus. On shifting the gaze straight ahead, there is a rebound nystagmus. On left gaze, there is a left beating nystagmus, severe oscillopsia on left gaze. She was being treated as a case of vestibular migraine. Mother, who also had similar episodes once or twice in a year, had a very mild disease. On left gaze, there is a left beating nystagmus. On right gaze, there is a right beating nystagmus. The daughter was treated with acetazolamide and she responded dramatically. Diagnosis: episodic ataxia type 2. Diagnosis of patients with acute onset persistent dizziness. Ask and answer 5 questions in sequence. Is there a central pattern of nystagmus? Is skew deviation present? Is head impulse test negative? Only applies to patients with spontaneous nystagmus. Are there any CNS signs on focused neurological examination? Is patient unable to sit, walk or stand without assistance? If any of these questions is yes, treat as a stroke, perform brain and cerebrovascular imaging, specifically rule out the vertebral dissection, admit for stroke with etiology workup, begin secondary prevention if no thrombolysis. And if answer is no, Give steroids, prescribe symptomatic medications such as antihistamines, but not for more than 3 days. Arrange early follow-up with neurology or primary care physician. There's nystagmus pattern in acute vestibular syndromes in emergency department. The next 2 slides are dedicated to it. Acute vertigo and obligor unsteadiness in the emergency. No nystagmus, normal finding, rules out vestibular neuritis but can occur in cerebral stroke. Rarely BPPV patients, particularly those with the short arm and the apogeotropic variant of posterior canal, BPPV may have continuous dizziness but may not have nystagmus at rest. Spontaneous horizontal nystagmus in primary gaze and gaze-evoked horizontal nystagmus that beats only in one direction does not distinguish between central and peripheral causes. These two are mostly observed with the peripheral causes of AVS, but they are not diagnostic. Direction changing gaze-evoked horizontal nystagmus is invariably central. However, it can have a benign cause like acute alcoholic intoxication, anticonvulsant use, particularly the phenytoin intoxication. Pure vertical nystagmus in ED should always be regarded as central finding. Pure torsional nystagmus is essential. The torsional nystagmus is found in posterior canal BPPV, but that is a positionally triggered episodic vestibular syndrome, not qualifying for AVS. Skewed deviation is central. It is not very sensitive, but if it is present, this should be considered as central cause of AVS. So spontaneous AVS, hence peripheral, no deafness, vestibular sedatives, early rehabilitation and follow-up. Hence central deafness or ataxia, neuro workup. Stroke is more a possibility than wernicke encephalopathy. Sometimes you may see a patient of demyelination also. No nystagmus, normal extraocular movements, no limb or truncal ataxia, medical workup plus minus neuro workup. So how these patients are triaged? Symptom timing segregates transient from acute persistent vertigo or dizziness. Hints plus, if you add hearing to it, it becomes hints plus, differentiates stroke, suspects from acute vestibular neuritis. Neuroimaging helps to determine management and disposition decision. Acute vertigo, definite stroke, lysis candidate early with neuroscience. CT to exclude hemorrhage before lysis. MRI is not useful, may be done later. Probable stroke, not eligible for lysis, late or no signs. Less than 48 hours post onset, observe or admit. Consider delayed MRI. More than 48 hours post onset, MRI from the emergency department to dispose. No stroke, vestibular neuritis, negative, hence treat and discharge or admit for fluids with balanced rehabilitation. The sensitivity and specificity of the hints examination is around 90 to 97% sensitive and 84 to 95% specific. It is not useful in patients with acute in the parieto-insular vestibular cortex, that is dorsal insula, acute embolic occlusion of the internal auditory artery, that is labyrinthine infarction, acute small infarcts in the cerebral hemisphere. So what Italians follow is more important is acute vertigo and unsteadiness. They look for nystagmus by Frenzel glasses. If nystagmus is present, which is spontaneous pluridirectional vertical, they take it as central vertigo. If it is unidirectional and if it is hit negative, it is central vertigo. If it is hit positive, they say it is acute unilateral vestibulopathy, but the patient is unable to walk unsupported, it is a central vertigo. If nystagmus is absent and patient is unable to walk unsupported, this is a central vertigo. If there is a positional nystagmus, they do a supine roll test and Dix-Hallpike test. If it is positive, it is BPPV. If the so-called BPPV is unable to walk unsupported, this becomes a central positional vertigo syndrome. I finish my talk here. Thank you very much.